talking when that little Hollywood square lights up. I know
That's me.
Dr. Carl Baum said he probably wouldn't be here until 1:20. So I thought we might shift around a little bit some of what's in our slides so that we're talking about the naloxone specific conversation when he's here to participate. I wonder, does anybody know if Trish was or was not coming? I think she replied that she would be here.
She can be awfully busy, so we probably want to just get started and then hopefully she'll join.
Okay.
There's a garbage truck outside my door, so I'm muting myself.
So if you thought John was going to run the meeting, that isn't going to happen with the garbage truck outside. Okay, let's see, have I got the right screen showing? Let's try that again. Everybody can see the slides? Good, okay. Not that it's terrifically mandatory this time around, but there are links. So today, some of the things that we were going to talk about, and I'm skipping introductions because I'm assuming we all know each other. The naloxone procurement, distribution, and related data tracking. We've got a little bit to report on information that we found and then information that we're going to have to come up with as a group. And that's the conversation I thought it might help to have Dr. Carlbaum be a part of. One of the things we can do before he gets here is to generate the asks that we wanted to have of some of these meeting participants, the wound care folks and the emergency department from BHC, Jefferson Transit. And as I've been through the last month, I'm thinking maybe it's time to pull the sheriff into this conversation. And then the next topic is to look at that grant that Chief McKern had found for some emergency medical services training and go from there. So maybe, John, we could start with you helping us to come up with what we want to ask of those future participants. I'm going to go find those slides. Apple, I think that starts on slide 7 or 8, which really
Thank you, Lori. Appreciate it.
Doesn't have anything
like
in there.
being blind.
Well, let me know if the garbage truck is too noisy. And so I have been corresponding with our wound care clinic and emergency department about joining us for a meeting, and they are both willing to do that. So the wound care nurse practitioner, Mary Allen, is willing to participate, as well as Catalina Lucino, she is actually a temporary replacement ER director. So she will not be the long-term ED director, but she's the temporary one. But I felt like it would be better if we had some idea about what we wanted to ask these folks before we invited them to come to a meeting. So I was hoping today that we could come up with kind of a list of questions or get your thoughts about what you wanted them to talk about specifically when they came to see us. So with that, I will open it up for comments.
Oh, good. There's Dr. Carlbaum. And Trish? Well, I saw Trish come, and then I guess she fell off.
I still see her, so I think she's here.
Okay.
I'm here. I'm eating lunch, so I'm turning my video off for a minute.
Thank you for being here.
So John, this is Apple.
Yeah.
Can you back up just a bit? You would like us to comment on what we propose issues are we would want someone in wound care specialty to address for this larger picture of the work we're doing in South County. Am I on the right track? I'm sorry if I misheard you.
Nope, that's exactly right. And then kind of the same thing for the ED director is what role do we want the ED director to play, and what what specific questions do we have for the emergency department at Jefferson Healthcare in terms of how they would augment or participate in the wound care work or in the harm reduction work that we're doing in South County.
And so with regard to that, are you speaking specifically, I mean, we're sort of at the phase where we're considering naloxone as a way to broker with the community around education about this issue. And then obviously we would move forward to potentially a syringe exchange. So are you expecting that you would see folks, well, you probably are, I should be speaking directly to the folks in South County, but you're already seeing folks who might even need wound care just as a matter of interfacing with them through the fire department or police, et cetera. I'm trying to get a sense of the tracking where this particular information fits into the scheme of the project here. And I know it does fit in.
I mean, I think that's kind of, you're doing a great job of restating kind of my question too, which is, you know, how would we interface with these services as we begin to develop a you know, harm reduction program in South County? And, you know, I would say probably the wound care services, in my mind at least, and, you know, please feel free to add to it, but wound care services would be more of a kind of a wraparound service that we would provide if we provide needle exchange.
Correct.
So my thought would be that we would want Mary Allen, who's the wound care nurse practitioner, to come later in our meetings when we're starting to talk about, you know, wraparound services related to needle exchange.
Yeah, I would agree. I guess that's why I was asking, not to be too compartmentalized, but if you think of this as a, you know, a brick road, we're kind of meeting mile markers along the way. Wound care is a huge portion of at least what I know from our SEP program. And it's really great that nurses staff that program under our roof because they really can manage some of that wound care in the moment with, you know, supplies right there in the room. And then they do, you know, pretty finesse triage onward to the hospital if the management of that wound care is, you know, too intricate or too complex for us to do right there in our pretty basic clinic. So that connection is highly important, I guess, down the road. But I think it's good you're asking the questions now because getting people on board at the early stage is very fruitful. They can sort of see it grow and see where they fit in, where their expertise is most needed.
And Apple, just one other, you know, kind of piece of information. I did query them about the, you know, the incidence of needle wound, you know, patients that they see in the wound care clinic, just to get a sense of the scope of the problem. And they said it's definitely it's definitely an issue. So I think it's important that we include that in whatever wraparound services that we develop.
Absolutely. And I know that one can witness, observe, and hear about wounds that need attention from folks in the community under different auspices. You might be seeing them for a different reason, but realize that they are struggling with addiction and have unattended wounds that are really in bad shape. So there's all kinds of moments, you know, where we may even be doing naloxone education and come across someone who's in need of wound care. I think education to the team in general about what is the scope of wounds that we see among this population, and what are the different treatment modalities, how intense, like staging the intensity of what that treatment looks like. Can it be done at the SEP location, just there in a little room with some, you know, alcohol pads and what have you, bandages, or is it much more in detail and a referral needs to be made? Yeah, these are all really good questions. So I'm merely just augmenting a comment here, not raising any questions about whether it's important.
John and Apple, this is David Carlwalm. I think you brought up a really interesting point about the direction of information flow, and I think it needs to be bidirectional. So I think we need help from the wound care team educating providers, whether that's pre-hospital providers or police officers or school district teams, on this wound is okay and just needs some, you know, soap and water, and this wound is not okay, and this wound is really dangerous. So that would be helpful. But I think I'm also intuiting, and I don't know if we have a needs assessment from opioid users, if there's a barrier to access, either geographically, I have to go to the hospital in Port Townsend, that's a long ways away, or stigma, you know, I don't want to leave and go tell someone I have a wound. I'll just hobble along and hope it gets better. And so somehow improving access, and whether or not that can be done technologically. You know, there's a falls clinic program that EMS partners with Jefferson Healthcare that has worked, I think, pretty well. It's been a little rocky with COVID because people are just busy, but where the providers see an elder who falls and say they need an assessment. And so the elder signs a form saying, yes, you can tell the hospital that you saw me. And then the hospital is informed of that. There's a paper and I think a building electronic version. I almost wonder if there could be an electronic version that uses photography of wounds. I think that's a powerful way to connect people with wound people. So all the wound experts I know, just, you know, their notes are all photos, and if you show them a photo, they can tell you right away that's okay or that's not okay. And thinking about if there's a way to break down barriers to extend the reach of the wound clinic to people.
John?
Yeah.
I wonder if now that we have Dr. Caldwell here, if we could pin this piece of the discussion, which was actually later in the agenda.
Sure.
Move ourselves up to the beginning, because I
Yep.
want to make it through that naloxone. Go
Yeah.
ahead.
Yeah, I just want to say I'd like to put a pin in this one and say, so I think what I'm hearing is general consensus that we might want to hold on having the wound care specialists come until we're a little bit closer to the, you know, the syringe exchange part of this discussion, and then have them come. And I took some notes about that I'll relay back to them before the meeting about the kind of things that we want them to discuss. And so I think we're in good shape on that. And when we come back, we can start talking about the ED director and where that goes. Okay.
Okay, great. Thank you. And I'm sorry for bouncing us around. I just wanted to make sure I had Dr. Caldwell here when we started talking about the, if you go to slide 5, and I'll share my screen. With the help of Apple, I was able to connect to, through a series of connections to Sean, I'm not even going to remember how to say his name, it's Hammerly or something like that. Anyways, he supplied us, he is a naloxone supply consultant, I think was what his title was. And he provided us with a form that we would fill out to request a supply. And my understanding is that if they accepted our request, that it would come basically free. Maybe there's some small cost, but there's not, but I'm sure there is a data, a robust data requirement with taking their naloxone. So and that was only in the past 4 or 5 days that I made that connection. Apple came back and had a very good thing that I could go back to him with, which was to say, is there a way, while he was trying to connect us with injectable naloxone, maybe the question is how much injectable versus nasal spray do we really want for the population we would be serving? So I sent out and asked him that question, and Apple, you can't see, but I have what his response was because it came in just before this meeting and after I'd sent out the slides. So basically he's saying, if you're, who is your primary audience, and is injection going to be something that they're already familiar with? And if that's the case, then maybe we can go with the injectable, because that is apparently what they have a lot more of. And I know that from having listening to their syringe service program calls every month, that the nasal spray is somehow much tougher to come in contact with. And I think it's a lot more expensive, and maybe that's why it's such an issue. So one of the topics for this group is, how much do we need of what type? And I am open to anybody, because I know nothing about this.
Well, the word from my staff who educate about naloxone and share it with folks within their SEP program and onward. It's available to our staff for their friends and family. It's been mentioned at many community meetings that people can come and obtain one from us. We don't pay for them. We're in a project with the University of Washington, and we do receive quite a bit from them. There is a lot of data to provide to the UW Department of Health, where Sean is coming from. They still have a data request, but I don't think it's as labor intensive as that from the UW. That was sort of, I think, Barbara Kingston's assertion. I think injectable makes sense in the drug using population. What I'm worried about is that the motive, I think, for starting with naloxone, and any of you on the call who've done more of this, please chime in. But the motive to start with naloxone was really to extend a hand to all types of people in the communities down in South County, to encourage them to get naloxone, have it on their person or in their car, and share it where it's necessary to prevent these overdose deaths and what have you. So I think maybe what you're saying, Lori, is that a combination of them is what's most necessary. And I just don't know what the proportions would be of one over another. Maybe someone else can comment on that.
Chief McKern.
Well, I'm going to actually lean on my doc, who's about 3 or 4 down there. The problem with the nasal spray is it's too big of a dose. Is that correct, Doc? We can't get it low enough. And Doctor and I have been commenting on that. Are you correct with that?
Yeah, it may be too big. It may be too big of a dose if the patient gets the whole dose.
Okay. So we can back it off. We don't have to give them the whole dose. I've always known it is you give them the whole dose.
I think, Chief, you'd have to teach me. I thought it was 2 sprays in the vial, or is it just 1?
I think there's only 1 in the spray. That's the problem. There's only 1 in the spray. It's a single. I've got to reach in and grab another one to do each nostril. So what you're saying then is, so what's happened is it's a pretty high dose, and the doc has asked us to down trade it. So in the field, we're now drawing up our own, and it works much better to do it that way. But we just can't ask Joe Citizen to do that unless they've been trained. And I see the nod from my doc saying, no, we're not going to do that. Now we got a whole nother mess on our hands, because now we're back into needles again. So, you know, I guess I'll call it the details there about it is, I guess it's better than no Narcan on board. How about that? So I think probably if I really think that probably the nasal spray is the only one that should be on the docket, because that's what law is using, Public Works are using. Any of the folks that are out there in the public are using that nasal, and I think that's probably the method we need to go with. Just my 2 cents for. You agree with that, Doc?
Yeah, I might do still some injectable for people that are comfortable with that and have previous training with personal protection or bloodborne pathogens. So we're able to put on gloves and drop a medicine and stay calm in an emergency and inject somebody, which might be injection drug people, opioid users who are using injection as their route of use. It might also be like a school nurse or someone who's, you know, a public works plow driver who also is a volunteer firefighter, et cetera. I think there might be a small group, and I was trying to think of the ratio, like 10% injectable, 15%. I don't know, but I think you would want to probably have some sort of criteria of them signing that I'm comfortable and have had some form of training in protecting myself from bloodborne pathogens.
So that brings to mind 2 things. One is, it sounds like in our training, there needs to be some sort of form that is signed. Yes, and maybe that's already out there, Apple, in the program that you use.
I'd have to check. I'm sure that we do, but I will look into that for you.
And then the other question I have is how, when we're putting together this request, and I can pull up the actual form, there's several things specifically. Now, can you folks see that form on your screens? So, you know, they have the overview of the organization name, etc. They want to know who will be responsible, and so that's something we need to decide among us for ordering, receiving, and distributing, you know, to wherever it's going to go out to. The address, we can talk about this. I think all of the questions on here, I would like to have some input from those of you who, one, know more about this kind of program, and B, are going to actually be using it. So that as I fill this out, we're putting something that actually is based in reality. And the link to this is in your packets as well, if it's easier for you to pull it up on your own screen. So there's this form that needs to be filled out. And then I'm thinking, for us, how much should we be asking for if we're thinking it's a, you know, as Dr. Kalbaum was saying, maybe a 15% of injectable and the rest is nasal. What kind of numbers are we looking at? And John, if you've got any ideas how we should be thinking about this to come up with that, I'm open.
I mean, my sense is that what will happen is once this is available in South County, we'll kind of load the system. So I think the demand will be pretty high initially as people realize the availability and can come and get it. And then, you know, and then my guess is that the ongoing need is probably pretty low ultimately. But so I think it's important to think of it in both those ways. What do we need initially to make sure that everybody in the community that wants it has access to it and can pick it up? But then what's kind of the ongoing need that we have, which will probably be quite a bit less. And those of you that live in South County might have a better idea. I mean, I'm thinking, I don't know, 100 to 200 doses initially, and then, you know, 10 to 20 a month after that. I don't know. I'm pulling that out of the air, but that's kind of my sense of that. And like I said, those of you that live in South County might have a better idea.
You're right on track with that. The initial 50 to 100 that'll be the initial phase, and then it drops way down. And that, from my experience in Mason County, the outlying counties of Mason, the Lillywops, the Hood Sports, you know, the far reaches of things, it was pretty big in the beginning, and then it kind of settled down, you know, back to a pretty Amish level more than anything else. One person that might be able to help, and I can certainly reach out to him, is Abe Gardner from Mason County. I have no problem reaching out to Abe to say, how many in the beginning did you initially start with, and where did you go? And because our counties are pretty much concise as far as the size goes. And so I can certainly, when I hang up with this conference, I'll get a hold of Abe in Mason County. And I see the doc nodding, so I'm kind of looking for his. That's pretty good with that. We don't want to ask him because he's going to give us Harborview numbers, and your 100 is in one day versus the 100 you need for a whole month.
Yeah.
Right.
Christian,
Okay.
if we wanted to give it to every graduating senior, how many would that be?
Well, in Quilcene, it was 16.
16, okay.
Well,
I mean, in Quilcene, I'd say 25
Okay.
or something like that.
There you go.
That's a round number of kids that are in their brick and mortar program, and yeah, about 25.
I knew, Trish, I knew you'd have the answer, so.
Should we talk about the logistics around ordering, receiving, distributing? John, I was going to let you take hold of that one.
Well, I mean, for me at least, the ideal would be to have it somewhere in South County where it's not you know, if there's snow on Mount Walker and it's hard to get to Brennan, you know, that some is available in that community. And the same with Quilcene, you know, that some's available in Quilcene, and if there's transportation, it's not a huge deal. But that would require someone in each of those communities to be the, you know, the monitor of that. And really for me, it's the fire and rescue or the schools are the likely candidates. And we have representatives from both on the call, and I'm just curious about your thoughts about being that place, or the hospital or the health department or other possibilities for that. But I think it would be preferable to have it, you know, received and tracked in those communities, in my mind.
Well, in this Quilcene and Brennan school districts, we don't have full-time nurses, and we just contract with the ESD to get nursing services. So it seems like the fire departments might have a little bit more expertise than I would.
Do you see it done, Dr. Caldwell, in other areas? Or Tim, do you know how it has been in Mason?
They use it through that. See, you don't have a well, they're using two things. They're using the health department, which is downtown, which is kind of a down Shelton. And then they do an outreach clinic, which is they've got a motor home that goes out to different areas of the community and kind of does that outreach, if you will. You can certainly do an outreach and a motor home type of setup. You know, on a Wednesday, you're going to get a lot of people because there's a lot of people. And Trish, you can jump in here. There's a lot of people at the senior center on Wednesdays when they do the food giveaway stuff, when they do that. And they're still doing it even through COVID. They still line up, and usually the line's down around the corner from the center. The other piece to it is, you know, one of the players that's not here, one of our stakeholders, was the clinic, the South Sound Clinic that was here in town. And JGH, I thought, was going to be a partner here. That I think that's where it needs to, that's the focus where it needs to go, because that's where we're going to get the drug take back program. I tried to get them connected up with JGH as well, to have them put that outside the clinic. I hate to focus on the clinic, but they've got the right setting with the provider, with the staffing that's there. We'll assist them, we'll help them, but as far as Quilcene taking it on, that's probably not a role for our guys here, and I hope my doc would say the same thing.
And I would like to add go ahead.
The difficult part for Brennan is we don't have the health clinic. I mean, so I think Chief Manley and I would have to get together and decide how best to manage it. I mean, I'd be open to suggestion, but we don't have that. We don't have the luxury of having a health clinic. You know, we have the weekly food bank, we have the senior citizen soup lunch on Wednesday, and you got the fire department and the school. So.
Apple, were you going to say something? Thanks, Trish.
Oh, I think Trish's point is well taken. I was only going to add that while we have experience, you know, receiving and storing naloxone at our main office in Port Townsend, getting it down there is with many other steps, so that doesn't really make sense. We do have satellite clinics, but we staff them infrequently enough that I don't know that would be helpful to you all. We do have our school-based health center that's opening up in Quilcene at Quilcene School, but again, we're only going to be there 2 days a week, and I don't know that, you know, harboring something that as valuable as that is reasonable when it would really just be sort of a holding place for those items. We don't staff those clinics all the time. I do agree, though, with the chief that South County Clinic makes a lot of sense. I don't know if they're planning to be part of this discussion or what, but that would be helpful. I think that's a reasonable place. Again, though, Trish is right. That doesn't help Brennan specifically. So I'm not providing much of an answer.
Apple, is there, and you may not know this, are there any special storage needs for naloxone? I mean, I used to use it in labor and delivery, and it didn't require any special handling, but I'm just curious if you know, or Dr. Carlbaum, you may know about that. I mean, it doesn't have to be refrigerated, doesn't have to be, you know, should be stored behind lock and key, but nothing special about it other than checking expiration dates is really the main issue with it.
We had immediate need. The Quilcene Fire would take it on, but it would be under lock and key, probably in my office, and it would just be kept that way. And the folks would know how to get to it if they had somebody that came by or we needed to administer it. In the meantime, till we can get the hospital up and running with the South Sound Clinic.
Well, I can take my chip hat off and put my Jefferson healthcare hat on for a minute and just I can certainly take on, asking our South County Clinic if they would be willing to be the receiver and distribution point for it in South County. And I think, Brennan, we may have to just transport it between Brennan and Quilcene, and just have one single distribution point for South County, which that doesn't seem too onerous to be able to do that.
We fall under the man that's on the call here. We fall under his license. So it's really in Dr. Carlbaum's. If he says yes, then we're good. If he says no, then it's no. We're all under his medical license, and whether we carry extra naloxone or so, Doc, it's really up to you. You give us direction, we'll follow it.
Yeah, I think, I was just trying to think of what location has the least barriers for people accessing it. I worry a little bit about the school sometimes, because I think some opioid users who don't have children at school would find that a barrier, right? They'd find, well, people are going to ask me why I'm going to the school, what's up? So I do wonder about a partnership in Brennan between the fire department and the school, having a little bit at each. Chief McKern, I do recognize that you don't have the staffing to always have someone in the building, that you have, pretty minimal staffing. And if you're out caring for patients, you're out. But I wonder about partnering with the health department, the clinic, where the clinic is primary, but you guys also have a stash that's available. So if people are uncomfortable going to clinic, they can go to the fire station. I don't know.
I'm okay with that. If the doc's okay, we're okay with that. But I like the point. I think the key word here is partnerships. And Trish, I like your idea of partnering between you and Chief Manley and Brennan. That's great. And we'll do the same thing with the South Clinic in the meantime. So no worries.
Yeah,
Okay.
and Chief McKern, I still am a huge advocate for having an extra sort of public naloxone on your unit, so that if you do meet someone who you give naloxone to and they refuse transportation, you can leave it with them or their friends as an intervention.
I can tell you, Dr. Hoffman requires it down in Mason County. They're required to carry it on board, and it's in a little Ziploc baggie, and it's there for you, and they're given that. But the paperwork, there's the paperwork that you guys just saw. Lori pulled out the form, and there's some forms that need to be filled out.
Yeah, it may eventually be required. I usually start a little soft.
Yeah.
So I can't answer for Jefferson Healthcare right now, but I can take that to the next step. And so I think what I'm hearing is, let's have the Quilcene Clinic be the ordering and distribution hub, and then Quilcene Fire Hall, Brennan, and Quilcene Schools would receive naloxone from the Quilcene Clinic if the hospital agrees to be able to be the distribution center for that. Does that sound like at least a working plan moving forward?
And I don't have Chief Manley here, but I feel like that in my very tiny K-8 school, I feel like that it might just be safer, better to have it be more with Chief Manley. And I haven't talked to him. I think he would be open to the idea, but I'm not trying to wash my hands of it. I think that John and Lori particularly know me to be someone that will jump in and help in any way, but I'm just throwing that out there. So
on the fire service, I can speak for Chief Manley. I'm sure he's going to agree with you, Trish, and it'll be fine.
Yeah, he and I get along real well. So anyway, but I want to help.
John,
let's start out with that plan and kind of see where it goes. So Trish, we kind of sounds like maybe take you off the list, at least initially, unless people feel like, I don't know if the fire hall would be a barrier, if we need kind of a second place that potentially people could go to, to get naloxone in the Brennan community, or whether you guys feel, Trish, maybe you and Chief Manley could just talk through it and see what you guys think about. I think it's nice to have two places in a community, but You guys talk it through and let us know what you think.
I'll reach out to Frank and try and get the admin offices. We're done, like I said, so that's two to-dos that I've got to do. One is to contact Abe down in Mason County, and then I'll contact Frank over at the school to try to set a meeting up with him today or tomorrow, and we'll make that happen. And then maybe Trish, we'll have you and Frank kind of connect up as to how much you want, and then we'll make sure we get that supplies to you and get the supplies back to where we need to get it.
Lori, is there anything else in the form that you feel like it would be good for us all to talk about before we move on?
I'll get that up on the screen while Apple asks whatever was on her mind.
I'm sorry that I cut out you all. I know, John, you were asking me a question about storage of naloxone, and I pushed the wrong button and hung up on you. I apologize. Storage and its particulars, I don't think is complicated. I'm sure there are people on this call who know the answer to that. Whatever our protocols, I can certainly share with you because we have those types of things.
I think
written
between
down.
us, we figured out that it's
pretty
simple to store.
Yeah, right. There's no refrigerator involved and that kind of thing. My question is a little bit far out there, but I just am wondering, I'm fairly new to SEP work in general. I'm wondering, for those of you who did this in Mason County or have done it otherwise, is there anything, and I can think of a few reasons, but is there anything precluding a community partner from receiving and retaining and then distributing naloxone that is in a business? Okay, so I know we've talked about law enforcement and rescue, and we've talked about schools, and I know that, libraries have been involved. Is there anything precluding a grocery store or another place of business in the community from being a partner in retaining some of these kits? It sounds a little iffy to me just hearing myself say it out loud, but I'm just wondering from other people's experience in a small community where you have, not a lot of community players.
I'm thinking for Brennan, that might be something to consider. I mean,
I'm thinking of the gas station on the main road. Goodness. I don't know. I don't know what that attracts.
I mean,
how that works.
I was thinking this. I mean, in a land where we're trying to limit visitors into our school right now, it's
Right.
hard to say, come one, come all, come get this whenever you want, and just let anybody who wants to walk in. It's a little difficult right now.
Well, and the form does say, it's very specific about receipt of shipments, that you have to put in how available is this address, and that they can't be received at a PO box, et cetera. I'm just trying to think of entities that are open a lot, open 7 days a week even, and there wouldn't be many in your area, so there's not a lot to choose from. But I'm just wondering how creative the end receiver could be in this case.
Apple, do you or does anyone else know? I mean, could we have it all come to the Quilcene Clinic and then have them distribute it to other places in the community that would be doing the, the endpoint distribution? Are there any issues with that kind of a model? Or does each place that's distributing it have to receive it itself?
Well, it's a really good point to clarify. I do not know. That's a very good question to ask. I would encourage you, Lori, to ask Sean that very question, because that might line us up in terms of what we're able to even imagine doing.
I will do that. I'll touch back with him with some of the questions that have popped up here and see what I can come back to you all with in terms of insight.
Yeah.
So you talked about the questions on this. Chief McKern, did you want to say something?
Yeah, Apple, I think you're on spot with that. I think that you're great, and I think it's awesome that you're looking at a 60,000 foot level. Unfortunately, I think we need to do baby steps and work it at a 10,000 foot level today. Your question was brought up amongst the stakeholders, and the meeting that we're currently having with 5 of us in Mason County was 150 people, and the same question came up. And I can't see, they said down there, I can't see it going to every mom and pop store in Mason County and the Walmart and the QFC and all those pieces was way too big of an animal to deal with. So we got to be careful. I agree that there's a store, but I can tell you that if I took the Narcan and I took it into the store in Quilcene at the Peninsula Foods, those folks in there, I've got to explain it to them because they do speak a different dialect, and so I've got to explain it to them, and they're not going to want any part of it. I can tell you they're going to put their hands up and go, "Get it out of here! I don't want to deal with it." And so I think you're going to have two different aspects of it. Now, could I see it at a restaurant in town? We only have Tawanas, and we have a couple of Tawanas in the gear. But could I see it there? I can't answer. Now, would we see it potentially at our community center? And the answer is probably yes. I think come time, as we need to prove what's currently happening and make it right, and work through the process through the school district to make it right before we. I'm just saying baby steps. That's just my opinion.
I totally agree with you, Chief McCurran, for what it's worth. I mean, I think if we could get it out in 2 or 3 places in both of those communities and then talk about, where we go from there. So.
And I agree. I like this idea of a pilot. And I also wonder if at the pilot sites, you could start even informally asking people, how could we make this more convenient for you, and do a needs assessment? And people maybe they'll come with a location that none of us have thought of even. And then we could pursue that. But I do think we'd need to have some bomb-proof education, whether that's just a link to the Washington State Department of Health Vimeo site that I thought had a good video that you sent us, or a couple other videos, so that the store owners don't feel like they're obligated to do the education.
So I'm going to just go back and share the screen on this this form that we're looking at, just to make sure we've kind of covered any questions that I should come up with, or that I should go back to Sean with. So there was we talked about the physical address. There is going to be a need for training, no doubt about that. And on our next component of our agenda, we're going to talk a little bit about that. How are we stepping out into the community, beyond this group, as we start to go to the next level with this proposed program. So there's the training, there's the how many, which we've talked about, and I've got some questions to go back with to Sean. Now, this monthly reporting, I think that collecting that data is what we would need to figure out how that's going to happen if we are distributing them from a main place into subsequent, fire hall, whatever other locations we decide to do that. Any thoughts on that one? Just, it's going to be something we'll have to figure out.
This is David. I appreciate the need for data. I personally kind of feel like this is a barrier. If you're like, oh, let me write down your name, or let me fill out a form while I give this to you, I think people who might be skittish, that could be a barrier. So it might be nice to better understand how much they mandate.
Okay. And you see that they say, if you have concerns about the ability to hit this, say so here. And I bet we could make a very articulate argument for why that would be a barrier. Okay. And then there's the shipping address verification, copy of their credentials. So we're assuming it's all going to go to one location. So we're only going to need one credential. Okay. And I think that's everything. And then in this PDF that you have at your link, I also have included the back and forth that went on to get to the point where we got that form to us, so you guys can see the questions that went back and forth.
And Lori, I might propose, if you wanted to, whoever wants to start on this, do a first draft and then send it as a Word document. We can use track changes to make edits or suggestions.
I really like that idea. Okay.
And then I also noticed that it's McKesson, just, they already have my licensing information. I'm happy to sign for the drugs if the South County Clinic physician or licensed practitioner is not. I'm happy to be, they already have all my DA and everything, so.
Oh, great. So John, I'll leave that knowledge with you as you're exploring that with the hospital.
Got it.
Okay, we're at 1:47. The next topic is a big chunky one, but let's at least step a little bit into it. as John and I were talking with our technical assistance person for the grant who is funding this effort, he came back with sort of these 3 things that we needed to be thinking about as we're doing this program or as we're trying to set it up. And he gave some suggestions about things that we might be doing at this stage that will set good foundation for the following stages. And so I don't know if can you even see the slide, or is it unreadable, this bit over here about the 3-pronged bits to success. One of them basically is that we spend some time, even when within this group, articulating for ourselves why we believe naloxone education is the right thing. And if there was ever a time where you didn't, or you were on the fence about it, what your process was to get to the place where you thought it was a good idea. Because if we can say it to ourselves, we're going to be able to say it to folks going out into the community. And so maybe at some point we spend some time, and I know we're missing a couple of key players today on this meeting. And then, so this is just around the naloxone education. I'm sure that there's also a good deal to articulate to ourselves around the service, the syringe exchange program aspect of it when we get to that point. And then also, one of the things that I thought was a really worthwhile suggestion was this: how can we initiate the conversation so that anywhere where there are needles currently, we ask the community to let us know where they're seeing them, so that we can go out and start cleaning them up, and we know places to target when we actually walk out there with the program, so that those are not the places that people point to and say, you started a syringe exchange program and now you have more needles. That's sort of putting the horse before the cart or something, so that we're addressing that out in the community before it has a chance to be used against us. And then, John, this was something you were talking about, was perhaps doing something at the Quilcene Community Center, which I know is complicated with the COVID.
Yeah, I was thinking that having some kind of an event at the Quilcene Community Center and, letting people know what it is that we're trying to do, and, covering some of their concerns, potential concerns about it. And also, it's an opportunity to find out what the specific issues that either the Quilcene or the Brennan community have. So we were thinking about having some kind of a kickoff event, near the start of the time that we make naloxone available. And then we could also give people information about where it's available in the community, and maybe even ask the question, is there anybody else in the community that would be interested or willing in serving as a naloxone distributor for the community?
Any thoughts on that? Is that something you think is a good idea, or something you think is maybe less of a good idea? It's a good idea. Okay. And then the next stage will be, but this is a little bit further from where we are, is building that relationship with the folks who use drugs. Thank you, Trish. So maybe next time we'll spend a little bit of time talking about, because it feels to me we've got a small group here and we're all relatively on board with the idea. I think that there may well be people who will show up at a community gathering, or even after this thing has been introduced, who really feel strongly in some other way. And we should have some way of reaching out to them before we do it, 1, and 2, making sure we have a way of talking about it that, that it gives them a chance to sort of come into their own understanding of why it might be a good idea to have naloxone out there. Trish, were you raising your hand? Or no? Okay. So now I think we can go back to the discussion that John was talking through. I think we're going to pick up with the emergency room next.
Lori, I think because we have such a limited time left, maybe we should talk about the grant piece in the time that we have left.
Chief McKern, do you want to talk a little bit about what this was and when you saw it and what you thought as you saw it? And do you want me to pull up the actual grant?
No, it's a rural EMS services trauma grant. It came to the Northwest region. I know that Dr. Carlbaum and I both saw it. I have not, it started when I read it and looked at it at a glance. It really had your guys' names written all over it, and I didn't want to duplicate anything. So really, we sent it to you folks to say, if you're interested, jump on it. I know that Dr. Carlbaum and I will support it from the regional side of things. Anything we need to do to support it. It's not something I don't think that an entity should jump in and try to, because really it's a duplication of services. And if that particular entity that's running that grant sees the duplication services, we're not going to get it anyway. They're going to pull it in a matter of seconds. So it was just more in the lines for you and John to look it over and give us your 2 cents worth to say, hey, it looks like something we can do. Or it's, hey, listen, we're not there yet. It sounds to me like it's a grant that's going to come up each year. I just wanted to make sure if there's a grant opportunity, we're going to jump on it. Doc, you agree?
Yeah, I think my only addition is, you guys clearly are successful grant writers in that you have a grant already. And I thought a lot of the language that I imagine that you used for the current grant could probably be used for this. So I didn't think it would be too heavy a lift. And I thought it might meet a niche of one aspect.
I'll go ahead and share my thoughts, Lori, if you want me to. So Lori and I spent quite a bit of time looking at it, and I think it felt a little limiting to me in that it's so focused on education. And I think if we're going to go after a grant for this work, we would want something that's a little broader that might be able, if we needed funding for an naloxone or for a lockbox or for something like that, that we could, we could get something that was a little broader. And then it was also a question of who would administer the grant. So the health department's administering our grant, but they actually have a pretty high overhead in terms of, their administrative fee to administer the grant. And so we would probably be looking to, one of the fire districts or, EMS to kind of be the sponsor for the grant. And that's a hell of a lot of work for someone to do. So I think this just didn't feel quite like the right fit to us. Having said that, I think I would want to clearly send you guys the message to keep sending these to us, because I think there probably is a grant out there that's a really good fit that we would be willing to take on. So we didn't want to discourage you by saying this may not be the right one, but encourage you to keep doing that. And Lori, feel free to add anything to what I just said.
Yeah, I agree. That one particularly, I thought, I don't know that we'd want to, I don't even know that we could run it through public health, and that's, where the current grant is run through. So that was sort of my first line of thinking, is how would we even administer it? But absolutely, please do continue to send us any opportunities you see that sort of sound like they fit, because we are going to find the right one, and we're going to buy ourselves an RV or something with the money we get from it.
Some of the places that have done it, John, I agree with you. Some of the fire departments that I've seen, I read their grant, I looked at their narrative, but it really was defeating what public health was trying to do. And we can't go down the avenue of having two different grants. We can't.
No, yeah, I agree with that too.
Fire department X is pushing for this and this and this, naloxone and needle exchange and all the rest of that. And yet the health department is doing the same thing. And we don't want to do that. We want to send one message to our community, not multiple messages. So
yeah.
Personally, the person from I speak for Dr. Carlbaum and I, we're not taking any offense by it. We just wanted to give it to you to say, if it'll work, we'll support you. We got you behind you. We're behind you on this one. And yes, you're right. There are a multitude of grants. Out of a blue the other day, just speaking of grants, I found that, who knew that Firehouse Subs was going to buy us a extrication tool? We never even thought in the wildest dreams that they were going to come up, and it did. Like, bloop, there you go. And it drops in our lap. So those are important things that you just need to look. They're out there.
Okay.
John and Lori, thanks for reading beyond the title, which is about all I read when I first saw it.
Well, we take you guys seriously. If you send us something, we'll definitely dig into it. I know we're here at 1:57, and so I think we'll just stop where we are in the course of what we were trying to get through today. And is there anything anybody wants to say before we end for today? And I'll run off, summarize the things that we want to do, send that out. I'll get working on the things that are on my to-do list and plan to come back to you, if you're okay with it, to do our next meeting on Tuesday, March 16th at 1 p.m., if that works for your calendars. All right. Are you okay if I just send out a recurring invite for that, whatever number Tuesday in the month it is? Okay, I'll do that. Any other thoughts that people have before we close out for today?
Yes, I just want to let John know, I think the ED does play a central role, and you guys are probably not quite completely aware of this. Every time the EMTs or paramedics see patients, they often call the emergency department. I think every time, and so we sort of need them to be plugged into what this program is and what's going on, and probably to have a champion also, because I could imagine they could also be helpful in distributing both education and positivity and naloxone, but in particular for the firefighters, if they're going to be giving it out, the docs and nurses in the ED need to be aware. So
awesome. Thanks. And I'll see, maybe Catalina can come to that. I'm just unsure because she's so temporary. And by the next meeting.
I think Lori Tinker is handling most EMS stuff sort of with Catalina.
Okay.
So you want to reach out to both of them.
Okay.
Lori's very wise and will certainly support it. But just sort of hey, this is on the horizon. Think about what you guys want your role to be. It'll at least have to be education / advocates, if not champions.
Awesome. Thanks for that feedback.
Yeah.
Okay. And I would just like to add, Lori, to be sure, if you put this invitation out as a recurring series, would you be sure to add Margie? I realize she hasn't been able to attend. She's got COVID case investigation and COVID pod vaccination planning going on like nobody's business. So she hasn't been able to come, but she would be a valuable part to this discussion in ongoing. Thank you.
I'll absolutely make sure she's on that invite. Thank you. Okay, we appreciate everybody coming today, and I thought it was a good discussion. We'll see you.